Hello and welcome to NOAHE Rounds. This is the seventh session of the academic year and the second last one for the academic year, in fact. My name is Brian. I am the Senior Principal Economist at IHE, and I will be facilitating today's session. In the spirit of reconciliation and gratitude, the IHE acknowledges what we call Alberta as the traditional and ancestral territories of Treaty 6, 7, and 8 regions of the Métis settlement and the 6 regions of the Métis nation of Alberta, whose histories, language, and cultures continue to influence and enrich our community. It's my pleasure to welcome today's speaker, Dr. Tim Zhang. And Tim is an economist and currently a postdoctoral fellow in health economics at the University of Calgary. And he holds an MA in economics from the University of Texas and a PhD in health economics from the University of Toronto. Tim's research focuses on applying economic theory to better understand the behavior of healthcare providers and using rigorous econometric methods to evaluate the impact of health policies. Today's talk is titled Physician Financial Incentives and Dialysis Modality Choices, looking at evidence from fee schedule changes in Alberta, Canada. I'd like to check, Tim, are you okay with taking questions throughout the presentation, or do you prefer to wait until the Q&A period afterwards?
Thank you for asking, Brian. Can you hear me okay now?
Yes.
Yeah, okay. So for background and for introduction related questions, I'm more than happy to answer them during the talk, but for empirical or theoretical questions, I prefer to answer those at the end of the presentation. Yeah.
Okay, sounds good. Sounds good. So just some housekeeping details. For the participants, you will be muted throughout the webinar. And if you have any questions, please submit them during the webinar using the Q&A function that you will see in the link or the Teams meeting, and the answers will be for Imperial technical questions will be answered after the presentation today, but any questions you might have on background, you can ask during the talk. So with that said, I would like to hand it over to Tim to present today.
Thank you, Brian. All right, let me share my screen. Okay. Thank you, Brian, for the warm introduction. I'm honored to present some of my recent work at this seminar, and I'm truly appreciative being selected as a recipient of the fellowship from NOAHE. In today's presentation, I will discuss physician financial incentives and dialysis choices using evidence from fee schedule changes in Alberta. I will begin with an overview of related literature and followed by background on dialysis procedures in Alberta and the relevant fee schedule changes. Next, I will walk you through a theoretical model developed to formally describe physician behavior, along with some of its empirical implications. After that, I will introduce the dataset and the empirical approach used to test some of the predictions from the model. And finally, I will share some preliminary results with you. Okay, physician behavior is widely recognized by economists as a central issue in health economics. So to study the impact of financial incentives on physician behavior, it is essential to understand the payment models used in healthcare systems to compensate physicians. Right? Fee-for-service is the most common model, but other mechanisms such as salary, capitation, pay-for-performance, episode-based payments, or a mixture of hybrid models have also been implemented to contain healthcare expenditures while maintaining care quality. Physicians primarily compensated under fee-for-service scheme tend to exploit their relationship, their role as the agent, influencing patient demand due to information asymmetry. This behavior leads to what is known as physician-induced demand, or PID, in the health economics literature. So a substantial body of literature provides empirical evidence on this phenomenon, right? So the earlier studies of PID, they focused on income shocks. So those studies typically examine the relationship between, for example, physician to population ratios at the market level and healthcare utilization. So the underlying idea is that an exogenous increases in the number of physicians within a single geographic area would dilute patient volume, right? So and then lowering physician income, and then physicians tend to respond to income loss by treating patients they do have more intensively. So healthcare utilization increases through the income effect. Another well-established approach investigates PID through variations in patient income information. These studies are based on the idea that well-informed patients are less likely to be influenced by physicians and more likely to resist deviations from their optimal level of care. So in a fee-for-service setting where physicians are paid on the margin, then utilization is expected to be lower among more informed patient groups, such as highly educated people or physicians treating other physicians. And the third major strand of the literature uses changes in physician fees to identify induced behavior. The key advantage of this approach is the availability of large exogenous fee changes, especially in the context like Medicare in the United States. So the empirical strategy used in the study I'm presenting today aligns most closely with this line of research, and we will delve into it in more details in the following sections. So most studies in investigating physician responses to fee changes has been, as we just said, has been conducted in the United States and often using Medicare fee reductions as a source of variation, right? Researchers have found that physicians tend to offset the negative impacts on their income by increasing the volume of procedures, right? So for example, for some procedures, the price being reimbursed from Medicare get reduced, and then physicians respond by increasing the volume of this procedure. So they try to counteract the negative impacts on their income. There are also other studies that have explored fee differentials across different insurance programs. For example, the Gruber paper examined fee differentials in Medicaid between C-sections and natural deliveries, and found that in states where Medicaid reimbursed the C-sections more generously, physicians tend to provide more C-section as a way of increasing their income. In Canada, previous research is more limited. So one study using aggregate provincial level data found mixed evidence of physician responses to fee changes across provinces and specialties. Another study showed that general practitioners in Quebec adjusted both the timing and the complexity of their workload in response to imposed salary ceilings and fee schedule freezes. Our study aims to contribute the literature by providing new empirical evidence examining physician behavior in the context of dialysis fee schedule changes in Alberta. Now, let's move on to the background of the dialysis procedures and the fee schedule changes in Alberta. So, dialysis is a life-sustaining treatment for patients with end-stage kidney disease, and understanding dialysis choices is crucial for improving patient outcomes and system efficiency. So, in-center hemodialysis and home-based peritoneal dialysis are the two main types of dialysis provided under Canadian kidney care programs across all provinces. In-center HD, the hemodialysis remains the most commonly used modality for new patients, for patients initiated dialysis, accounting for about 75 to 80%. Despite the peritoneal dialysis or PD is associated with similar overall survival rate, similar quality of life, and much lower costs. And as we can see from the fee schedules, from fiscal year 2005 and 2017, right? Between 2005 and 2009, the annual fee per patient on HD is consistently over $8,000 annually, right? And the number is considerably higher than those for patients that initiate the dialysis on PD, which gradually increased from about 2,500 to 3,800. However, there was a substantial increase in fees for managing PD patients in fiscal year 2010. So the annual fee increased from about 3,800 to 7,000 per patient per year, and it remained relatively stable to fiscal year until 2017. But on the contrary, from fiscal year 2010 to 2017, the annual fee for HD patients slightly declined. And there are 5 dialysis programs across Alberta. So in the 2 largest urban centers, in-center hemodialysis patients are managed by a weekly rounding physician, with all physicians, regardless payment model, participating in the coverage schedule based on their clinical time equivalent. In one of the urban center, we call it Urban Center A, the responsibility for managing PD patients is shared between fee-for-service physicians and salaried physicians. And in the other Urban Center B, there is a dedicated team of salaried physicians provide weekly rounding care for all PD patients. So the difference basically is for the increase in PD fees only affect one's fee-for-service physicians, in one of those urban centers. Then there are also remaining 3 rural dialysis programs that are each staffed by a single fee-for-service physician who manages both HD and PD patients. Previous studies found that no significant evidence that physicians in Alberta responded to the previously mentioned changes in dialysis fee schedule. However, these studies, they didn't provide an overarching theoretical framework to explain physician behavior, and they did not account for heterogeneities in physician financial incentives, which means they treat patients treated by physicians who were under different financial incentive schemes as a whole sample. This motivates the development of our theoretical model, which aims to categorize physician decision-making and address the following empirical observations. So why physicians may not increase the use of PD following only a moderate fee increase, and also why physicians operating under different financial incentives may respond to fee changes in different ways warranting separate analysis, right? So the model was built to focus solely from the supply side, and just as any model, it's a simplified representation intended to partially explain physician behavior. It is by no means a complete reflection of reality. However, I think it still offers some useful implications. Okay, so we extend a theoretical model based on previous work, right? To first consider a scenario that there is a single physician acting as a local monopolist, meaning they manage a fixed panel of patients who all require a dialysis, right? So this is not an unreasonable assumption if you think about those, for example, those 3 rural dialysis programs, right? Let's denote the panel size as capitalized N. So that's the physician has N patients, and each patient must be treated with either HD or PD. And under a fee-for-service payment scheme, the physician receives a fixed payment per patient, which differs depending on the modality choice they put on the patient. Specifically, HD is reimbursed at a considerably higher rate. In our case, if you remember, initially it was like around $8,000 per patient per year, compared to PD, which was about $2,500 per patient per year. However, the time required to manage a PD patient is lower than for a HD patient, as PD is typically home-based with fewer clinical visits. Importantly, we assume that patient health outcomes are roughly equivalent between PD and HD for most of the patients. So this creates a space for what we refer to as inducement. So there are room for physician discretion that can be influenced by incentives. Patients are not all the same. Some must be on PD due to, for example, clinical necessity. Maybe the physician cannot find vascular access on the patient. So we denote that proportion of the patients as alpha. So there are alpha N patients that are always on PD regardless of physician incentives. And then the rest, so the 1 minus alpha N patients are considered discretionary. So for these patients, that physicians can making decisions between HD and PD, and the decision can be influenced by financial and non-financial considerations. Then a key empirical question we want to answer is that why do we observe maybe physicians, they only want to sticking to just the alpha N patients, and when you increase the fee, the rate of patients on PD didn't change, right? So this pattern suggests that the physicians faces meaningful trade-offs that we want to model explicitly. To capture this trade-off, we construct a utility function with 2 positive components and 1 negative component. The positive components are income and leisure, each of which adds to the physician's utility, and the negative component is inducement, the extent to which the physician recommends a treatment that may not be clinically necessary for the patient. Then without loss of generality, we assume the utility function to be linear additive. So here, the Y is income, the physician income from fees, and L is leisure time, and I is inducement. So each of the utility term exhibits diminishing marginal utilities, which means additional income or leisure becomes less valuable at the margin. But the inducement term represent this utility from that increases convexly that the more physician-induced treatment, the greater the ethical or psychological cost the physician gonna bear. This setup allows us to derive predictions about behavior under different fee levels and the practice environments, and I will show you how we're gonna do that. Then the physician's problem, right, is to choose how many discretionary patients to treat with PD to maximize utility, which is basically pretty much to choose the N to maximize the physician's utility. We can then substitute N into the three components I showed you in the earlier slides of the utility function and obtain the following equations, right? I mean, income obviously depends on the number of PD and HD patients the physicians treat, and the leisure increases when more patients are provided with PD, since PD requires less time, and due to and the inducement is defined as the number of discretionary patients not given PD. To find the optimal solution, right? We take the first order condition of the utility function. When the fee differential between PD and HD is large, a corner solution is likely, right? Meaning physicians will only offer PD when it's clinically required, or there is only the patients who have a very strong preference for it. In other words, right, the model predicts that the physicians will voluntarily start shifting patients to PD from HD only when the PD fee becomes sufficiently close to the HD fee, right? I mean, it's basically this equation is telling us. So there is a threshold effect. Or put differently, when the differential between the two procedures is huge, and the physicians, when they care about their income, a moderate increase of the PD fee just will not increase the uptake of the PD procedure, because it didn't get to the threshold where the physicians are thinking it's worth making this trade or switching a patient from HD to PD. Now let's consider a scenario that two or more doctors form like a group practice that pools all dialysis revenues and then splits it among the partners, right? And then it resembles the situation of multiple fee-for-service practice physicians in one of the urban centers, right? Then for simplicity, that we can assume an equal split or a split proportion to workload, right? The key change is that the individual physician does not reap the full financial reward from one extra induced HD, nor bear the full financial cost of doing one extra PD, right? The income effects are shared with the colleagues. However, each doctor still personally experiences the time commitment and the disutility from inducing their own patients. So this basically dumps the effective income motive for each physician in a group practice. So which means the marginal income from inducing one more patient is lower than an individual for a physician in a group practice compared with a physician who have his or her own practice. So basically the threshold fee or the threshold effect we talked about to make the physician willing to shift some of the discretionary patients from HD to PD will be lower for patients, for physicians under group practice. Data. So we use the data from the interdisciplinary chronic disease collaboration, which includes all adult Albertans who initiate long-term dialysis in an outpatient setting, only outpatient setting. We didn't include the inpatient setting because usually patient who were initiated in the inpatient setting is 98, 99% on HD. So that's why we chose the patients who initiate dialysis on an outpatient setting between April 2005 and October 2016. The data set also contains detailed patient demographic and clinical information, as well as data on physicians' remuneration methods. Is either fee-for-service or salary. Those are the only two types of payment method in Alberta. We then examine the response of fee-for-service physicians to the increases in PD fees, right? The fee schedule changes across the 3 rural programs and in each of the urban centers using the following simple regression model. The model includes a linear year trend, right? The year trend, and also a a linear year trend, and also a dummy variable that's equal to 1 if a patient initiated dialysis in physical year 2010 or later, right? And then when the so that was the time the PD fee was substantially increased to a comparable level to the HD fees, from about 3,800 to about 7,000 per patient per year. So it's a dummy variable. It equals to 1 when it's past fiscal year 2010 and equal to 0 otherwise. The coefficient from the beta 2 here capture the immediate change after that PD fee jump. We also included an interaction term between the linear trend and the dummy variable, where the coefficient beta 3 captures the changes in the trend after the big PD fee jump, right? Additionally, we control for a vector of patient level characteristics, including demographic factors and the comorbidity conditions. We then ran the regression for 5 subsamples, patients treated by fee-for-service physicians in the 3 rural programs, because those programs were run by 1 fee-for-service physician per center. So they don't have a salaried component in it. And also patients treated by fee-for-service physicians in Center A, patients treated by salaried physicians in Center A, and then patients treated by fee-for-service physicians in Center B, and patients treated by salaried physicians in urban Center B. Let's first look at the regression results for patients treated by those 3 by fee-for-service physicians in the 3 rural programs. So there was no significant trend, as we can see, before fiscal year 2009. It should be post 2009, so it should be 2010. And then and also there is no immediate level change following the PD fee the PD fee jump. However, there is an upward trend since fiscal year 2010. So this basically suggests that physicians in sole practice, right, requires a fee that requires a PD fee, the close to the fee they can charge on putting patient on the hemodialysis on the HD before they start to increase the uptake for the PD procedure. And we explore the and we explore the sensitivity of the results by inducing different set of control variables. So in the simplest model, column 1 that we only included indicator for we have 3 programs, so we included 2 dummy variables to indicate only like the fixed effects of the dialysis program, right? And then in column 2 we added patient age squared, sex, income, quantiles, and number of comorbidities. In column 3 we further included a vector of 15 dummy variables that contains specific comorbidity conditions like cancer or obesity, things like that. The results, as you can see, are relatively stable across different regression certifications. Moving on to the regression results for patients treated in urban center A, where fee-for-service physicians benefited from the fee increases, the PD fee increases. There was already an upward trend, right, in PD rates prior to fiscal year 2010, and we also observed an immediate jump in fiscal year 2010, but after that, I mean the upward trend is no longer there, which also kind of makes sense because not every patients are suitable for PD either. I mean, there are gonna be a proportion of patients that from a clinical, from other for other reasons are more suitable for the HD procedure. And we don't observe similar patterns among the patients who are treated by salaried physicians. Since salaried physician, I mean, all those financial incentives we talked about don't apply to salaried physicians because and then for results from urban center B, in which they have a dedicated salaried physician team to manage all the PD patients, right? And therefore, the financial incentives for fee-for-service physician in that center didn't work, right? I mean, it's not there was no effective incentives there. As a result, like their salaried counterparts, their PD usage patterns did not change significantly over the study period. Yeah, that's about it. Thank you, and I will be more than happy to take any questions. Or the research is at a very early stage, so I welcome all the comments, questions, feedbacks. Thank you.
Okay, thank you, Tim. In your, I think 2 slides ago, there was a question from Sandeep Chand, and it was either it's 18 or 19. It's it was kind of in between. So he was wondering whether you considered excluding locum positions, and Sandeep, you might need to clarify what locum positions are for those who may not be familiar, but that's a question that he had. Tim, are you? where, I guess, do you understand the question in terms of whether you considered excluding locum physicians?
Locum physicians. I'm not sure. I understand the question. Can we like unmute and let him just ask?
Yeah, I don't think that that's option, but Sandeep can definitely put more details in the question in the chat to elaborate what he may mean by that. But I do, in the meantime, welcome any other questions that people may have. So it says here, physicians who see very, I guess, little number of patients.
That's a great question. Actually, for the rural program, we don't worry about that because we only have like one physician per center, and they treat like all the patients who have that demand in that area, right? So we wouldn't worry about that for physicians or for the patient sample that in those rural programs. But for urban programs, that is a very important consideration because the variation in terms of patient volume is huge. As we can imagine, there are a few physicians that had like tremendous volume, and the rest of them are just have like a couple of patients per year. So that definitely need to be considered, and I'm thinking about doing like more detailed analysis on that and see whether patient volume will be some sort of a will be a factor that have heterogeneity, will have different impacts on different on physicians who have different patient volumes, right? I think it's a great point. But for the purpose of showing that physicians who are in multiple physicians practice for group practice that behave kind of differently with a single sole practice setting, I think it is less relevant for that purpose, but I definitely agree that it might have an important effects on physicians who practice together at a large urban center. Patient volume is definitely something very, very important to be included. Thank you.
Yes, Sandeep, let us know if that answers your question, or maybe you might have a follow-up to that. Of course, I encourage people to put in their questions in either the chat or the Q&A. And okay, I don't know, just a message from Sandeep about how he's muted. I think it's just unfortunately, let me see what I can do. There we go. So you should be able to unmute yourself. If you want to explain a bit more. Oh, you're unmuted, but I can't hear you. So yeah, we're not getting any audio from you, unfortunately, Sandeep.
Hello.
Oh, yep, there we go. I can hear you now. Yes, we can hear you.
Okay, so great presentation, Tim. Actually, my research thesis, also around physician payment model. So I wonder, with locum physician, I meant like, the physician who are residents, like, they are in training and they go to the rural areas, and they have very less experience in providing care to the patients. And also there are some retired physician also who look very less
Right.
number of patients, and they are more into remote areas. Or there are also physicians who have apart from looking at the patient, they have other area of work, and they are not able to give more care or look more volume of patients, maybe every day. So these are basically the locum physicians, and I wonder how, if how it can impact the overall research. And if you have any thoughts around it, that would be grateful.
Yeah. Thank you. Great question. From a data perspective, from the data set I'm using, that I can only observe there was like a physician ID, right? It's a ID. It's de-identified, but there was like a unique ID number, and I could use that to link to physician some of the very general information, like the age of that physician, and where the age and sex of the physician, and where the physician was trained. Um, um, but I think if we have like more complete information of the physicians, that the question will be much easier to get addressed. So we can include some of the control variables of physician characteristics, and then, or maybe we can make them some as a variable of interest, and then we can examine whether physicians possess different characteristics, have is associated with some practice patterns. But unfortunately, I only have like very generalized physician information. Um, but we could, for example, create some proxy variables. For example, we can count for each physician, we can count how many patients that physician treat every year, right? And then we set like a criteria for like a certain number of for a certain number of patients per year. Then we account that physician as like full time, and then maybe for under for example, I'm just making up some number here, maybe 20 to 40, then it's like 0.5 full time, and then and etc. But one limitation of this approach is that we don't know whether it's truly physicians, they didn't devote enough time to treat patients, or the patients, they have a preference, and they tend to go to certain physicians, right? So we don't know that, but I think it might still be beneficial to look at this into more details. I'm just saying there is no easy and perfect solution to this very important question.
Yeah,
I
definitely. The Ontario, I think Ontario, they have a specific database that can be linked that provides physician details, but I don't know if Alberta has an equivalent to that where there can be some linkage.
There is a data set has some linkage. It's just the number of variables. It's not as many as the one in Ontario.
For sure, for sure.
Yeah.
Okay, yeah, great question. I'm going to move on. I think it's Zabin mentioned that in a comment that in group practice, overhead costs will be lower, so the financial incentive would be less. So yes, it is worth exploring.
Yeah, definitely.
For sure. For sure. I also have another comment here or question here from June, and it says that it seems that regression results show that all parameters for salaried equation are insignificant. Is there any issue with the variable selection? Also, any tests for other years except 2009 for the structural break?
I mean, we wouldn't expect those very well explain anything from the patients treated by salaried physicians because they don't respond to the financial incentives from the fee changes in a similar way as to the fee-for-service physicians, right? So I'm just using them as some sort of a control group. So yeah. But I would say maybe it definitely would be beneficial if we explore the maybe the cutoff points for the fee-for-service physicians and explore the setup of the specifications of the regression model for the fee-for-service for the patients treated by fee-for-service physician and see if the results hold up. Yeah.
For sure. And maybe Jun can chime in terms of if he can think of any other years that could be appropriate breaks as well beyond what was described. Maybe that something happened in something else happened in another year that could be worth exploring. I think that would be probably pretty helpful for you, Tim.
Yeah.
Okay. And another comment from I think Zabin. It says here another area that might be worth exploring is to see if there are gender differences in prescribing PD and HD. So maybe something worth exploring. Maybe there are differences.
Yeah, sure. Yeah.
For sure.
Yeah.
So continue to welcome any other suggestions, comments. It's all very helpful to Tim in terms of as he's developing the regression model. I have a comment here now, another comment from Alana, and it's or a question, sorry. And it says here, when you were describing the model setup, you mentioned accounting for the number of patients assigned to PD based on clinical necessity. Was the same consideration made for HD patients? For example, the number of patients required to start on HD for clinical reasons?
Great question. I mean, from a model setup perspective, in reality, definitely 100%. But from a model setup perspective, we only have like 2 procedures, and from the very beginning, it has to be either one, right? So from a model setup perspective, we don't need to explicitly build that into the equations in order to draw similar conclusions. But in reality, definitely this is a important consideration.
Okay, so Alana, hopefully that answers your question, but feel free to expand on that question if you would like. And June as well for you. Hopefully Tim answered your question as well. And do let us know if you have any follow-up or whether there's something else you would like clarified. So, Tim, another question I had was it both the time period in which you have the data set from I think it's 2005 to 2016, I think. And also, I get in terms of the 15 chronic conditions, were those just a function of the data or the data set and that it covered those areas, or was there any significance in terms of the data time period that you chose and the chronic diseases that were chosen, the 15?
Great question, Brian. So from the data set, there are 30 binary variables that indicate different chronic conditions. I chose those 15 based on the literature. That it says, from the clinical literature, it says, physicians definitely, consider some other chronic conditions when they assign the dialysis modality, right? I mean, so I included them as a control because we don't want the patient characteristics to vary dramatically, right? And then we wouldn't know whether, it's financial incentive or it's just the physicians were treating different patients appropriately or based on their clinical conditions. So we do want to include some of those conditions. And as the clinical literature shows, physicians usually took those information into account when they make decisions.
Right. Okay, that's interesting. That's good. Okay, and June also said 2019 might be another year for structural break test. From what I recall, I think the data set only went to 2016, or was it 2000? Was it later than that?
Fiscal year 2017, but I chose it to the endpoint to be October 2016 for the reason that later at the end of 2016 there was another intervention program called START project was implemented with the specific focus from the provincial government to increase the use of PD. Obviously, any study past that will be confounded with that project, right? So so that's why unfortunately our analysis has to be carefully selected based on the study time period. Yeah.
Yeah. And I guess the caveat to that then is that the results that you are showing are a snapshot in time that doesn't reflect ongoing policies that have sort of changed the fee structure.
Definitely. Yeah. And also the sample size, although we are using data from the whole province, but the sample size is relatively small, right? For
Yes.
purposes, right?
Yes, yeah. But I guess that's an issue with dialysis studies in general. It's not a huge population, right?
Yeah.
Okay, very interesting. So this is the last call for any additional comments or questions that people have. I'm going to take a look at both the chat and the Q&A sections, see if there are any additional comments or questions that people may have. Give it a little bit more time to see if there are. Okay, I think we do have some more questions or comments coming. But I guess in terms of next steps, the sample size. So there's a question from Ethan about what the sample size was.
Yeah, I have the sample size here. It's about 400 to 800 per subgroup. Overall, it's a little bit over 2,000 patients.
Yeah, it's always a struggle with when the numbers aren't that high. That one way is to expand the time period, but then of course the further back it goes, the less relevant it becomes, and so it's always going to be a challenge to balance that, right? The sample size with how far back you want to go.
Definitely.
Yeah, for sure. But yeah, so it's so yeah, that was the sample size, and I think in terms of next steps. So what's next in terms of your model, your studies here?
I definitely gonna take a look at the comment and the questions raised. For example, maybe in those large urban centers that physicians with different patient volume might respond to the fee changes differently. I think that is definitely one perspective that I would love to take another deeper look at. Yeah, and then I also need to make sure those results are robust by testing some of other specifications of the regression models. And also the theoretical model needs some more work as well. I mean, as I said, the study is relatively at a relatively early stage. So yeah.
Mhm. Absolutely. And we look forward to seeing maybe sometime in the future, can maybe provide an update when you get closer to completing to see how and what things have changed and what other additional insights you may have seen along the way. But yes, I thank you so much for your presentation today. That was very, very interesting. And I thank you to others for their questions and comments. And it seems like it's helped Tim a lot in terms of looking further into certain areas. So our next seminar next month will be presented by Dr. Rebecca Marsh, and that is scheduled for June 16th. We ask that if you have any questions or if you want more information about this session or future sessions, to please visit our website, noah.ca, and also to register for any upcoming sessions. That's the website that you would go to, or subscribe to the mailing list to get updates on our events and opportunities that may come up. Such as the NOAHE Fellowship that Tim is a proud recipient of, and we're so glad that he received that award. So thank you again, Tim, for your presentation today. I thank you everyone for attending, and I look forward to seeing everyone back here next month.
Thank you, everyone.
Okay, thank you. Bye.